Debate is early POAG. What is my first choice? Medication versus SLT. Dr. Mayav is going to talk for medication.
So good evening, everyone. Many thanks to Team Ajanta and Dr. Raju and Dr. Shafali. Just before I start, my opponent for this is Dr. Parveen Revi. He was my senior in Shankar Nethralaya, where I first joined as a postgraduate, and now we are debating together. So it's a great moment, sir. So I choose anti-glaucoma medications, which is the better initial strategy for early POAG, in my opinion. So, glaucoma over the years has seen various new technologies and its evolution over a period of time. But has that evolution been sustained? We have various new IOP measuring devices. We've had the ocular response analyzer, the dynamic contour tonometry, but still the Goldman's obturational tonometer remains the gold standard. Newer perimeters, VR perimeters, headset perimeters, device-based perimeters, but Humphrey Octopus still remains the gold standard. When I was a fellow at that point of time, the HRT and the GDX with all their various colored graphs were absolutely the in thing where we had to know it. But now those machines don't exist. And still for structural damage, we still have RNF velocity and GCC as our gold standards. Newer surgeries, MIGS, angle MIGS, non-angle MIGS, all sorts of MIGS. But in any surgical glaucoma session, you'll hear trabeculectomy is still the gold standard. Similar, different tubes, smaller diameter, larger plates, wire, non-wire, but still EMA the barbed are most used. So in the argument between AGM and SLTs, I choose AGMs any day of the week. And the answer and the reasons are number one, it is completely non-invasive. Two, widely available. I had a patient who reached Dhule district, which is 400 kilometers from here, not in the main town, called me at 10:15 that this particular drop is not available. There were three or four alternatives of different companies, good companies, and that the patient used. So any nook and corner of the country, you have glaucoma medications which can be used. Highly effective, up to 35% IOP drops, which are usually seen with various kinds of glaucoma drops. Immediately reversible. Patient has an adverse effect. Patient is not comfortable. If IOP drop is not significant, just stop the drop. 3 to 4 weeks washout period, and the effect of the drop is not no more. Again, can be adjusted according to the response. If you have a response which is not enough, you can increase. If there's a response which is more than what you want, you can always change to something which is less efficacious. Range of drug choices from 3G analogs, beta blockers, alpha agonists, and of course, the new kid on the block, which is the rho kinase inhibitor. All ophthalmologists are familiar with all kinds of glaucoma drops. Patients know how to use the drops. What are the adverse effects? What are the side effects? What is the contraindication? Whom to give, whom not to give? It can be customized. Customized in the sense, depending on the systemic status of the person, you can customize the treatment. What do I think are the issues with selective laser trabeculoplasty? Lack of accessibility, fewer machines, not universally accessible. In a city like Bombay, which is almost 2.5 to 3 crore people, Rajul sir, how many machines do you think are there in Bombay and SLT for a population of 3 crores? Do you think that's enough? So smile says enough. The light trial, 15 to 20% showed a non-responder rate. And that non-response increases when you go into the second, third sitting. So you have at least 2 out of 10 patients who do not respond to SLT. As I said, the response is unpredictable and there's a lack of obvious endpoints. You may see champagne bubbles sometimes. You may not see 180 degrees versus 360 degrees. And many studies show a less than 20% IOP drop. We don't know who the non-responders will be, although the China cohort of the light trials showed us that older females and low baseline IOPs are the ones who respond less, but still that does not cover a lot of people. Side effect profile, you see IOP spikes, uveitis, peripheral anti-synapsia, corneal edema, and even foveal burns in some. Is it cost effective? I am not sure with the machine costs and the cost to patient. So now Dr. Parime is going to give me arguments pro SLT, which I will debunk right now. So it says that it avoids compliance adherence issues with AGMs. I don't think for a single drop for a patient to use, if there's proper chair time, if there's proper counseling, if there's proper patient support care, alarms, you can improve compliance in patients. Is it cost effective? I am not sure. For each session, which could anywhere between 15 to 20,000 rupees, you can have a single drop for 5 years in that cost. So I'm not sure whether it works as cost effective. Anyways, after 5, 6 years, the patient may need medications. Drop free life. Again, this is temporary. For a few years, you will start medications again. Repeatable, yes, it is repeatable, but is the effect as good as the first time? No, the effect drops. Yes, it is proven in LITRA to some extent. However, it was a very highly protocol driven study, primarily in UK. NHS, which I've already said, has a high non response rate. So, my closing arguments are a lot. I mean, I've heard a few glaucoma specialists talking about that treatment should be taken out of the patient's hands. You should not let the treatment be in the patient's hands. So, example, you have a medication, you do SLT. If you have a person who needs treatment, you start SLT. If SLT does not work, you do MIGS. If MIGS does not work, you do TRAB. If TRAB does not work, you do tube. And then finally, if all this does not work, you go back to medications. It's like telling a patient who has early chronic kidney disease that you undergo transplant right now itself. And when you have options of medications, lifestyle changes. So I believe the treatment should be in the patient's and as well as in the ophthalmologist's hands. Glaucoma medical management, according to me, is four important criteria. It should be safe, it should be personalized, it should be reversible, and it should be adjustable. And according to me, anti-glaucoma medications are fit all these four criteria. Medical therapy with AGMs is all of the above and should be the first choice in early POAG without any doubt. Thank you. Thank you all to my
Okay,
Martin.
thank you, Dr. Mayav.